Muted.
And welcome everybody. Today we're going to talk about the QPP, the Quality Payment Program, but most specifically the MIPS portion of the QPP. So let's back up for just a second so everybody knows where all this came from, right? What are MACRA, QPP, Advanced APM, and MIPS? MACRA is the Medicare Access and CHIP Reauthorization Act of 2015. This is a law. It is very different from the ACA, so don't be confused when you hear all this stuff about repealing the ACA. That will not impact MACRA. This is here to stay. As portion of MACRA, the QPP, or Quality Payment Program, was introduced. What is the QPP? There's really two paths to success in the Quality Payment Program. One is participation in an advanced APM, APM standing for Alternative Payment Model. The advanced is the really most important word in that little acronym. The other portion is via MIPS, the Merit-Based Incentive Payment System, which is what most of you folks will be doing. So what, makes up an advanced APM? We've got listed here from the top down the OCM, which is the Oncology Care Model, CPC Plus, MSSP Tracks 1 Plus. If you're at a Track 1, it is not an advanced APM. And the 1 Plus program really doesn't kick off until next year. So essentially, if you're in a Medicare Shared Savings Program 2 or 3, Track 2 or 3, then you're in an advanced APM or a new generation ACO. Most of you land in the MIPS world, which means you are going to participate via the 3 performance categories: quality, advancing care information, and clinical practice improvement activities. We've got a little sort of Batman POW there that says cost on it. That is to remind us all that the 4th performance category is cost. We're getting a free pass on cost in 2017, but we do need to be reporting in that performance category on 2018, and so we want to all be aware so we're not really caught by surprise when that hits us in 2018. So we'll touch on it a little, but we're not being measured on it this year. So that's kind of the history of this whole story. It's important to understand who's eligible. We've got a little grid here that shows us the different provider types: physicians, physician's assistants, nurse practitioners, clinical nurse specialists, certified nurse, registered nurse, anesthetist. All are eligible for participation in MIPS. And this is like super confusing because there are different degrees of participation. We're going to touch on that just a little bit. You also, as an eligible clinician, that's kind of the new verbiage for the providers who participate in MIPS, you're called eligible clinicians. There are some caveats regarding your volume of billing to Medicare. So you have to bill more than $30,000 and provide care to more than 100 Medicare patients per year. I'm trying to help folks understand the participation rules regarding physicians versus those other, let's just call them mid-level providers for this discussion. The physicians were the ones that participated in meaningful use, right? Our physician's assistants and nurse practitioners, et cetera, participated in PQRS, but not in meaningful use. They are sort of continuing along that same philosophy with MIPS. So that gets it really confusing. Suffice it to say, so this little blurb I've got here at the bottom of this slide discusses the automatic re-weighting of that ACI performance category. Those points will be re-weighted to the quality performance category for those mid-level providers who traditionally did not participate in the meaningful use program, which ACI, as we all know, is inherited from MU. So those mid-level providers will still participate in MIPS, but really they're going to be doing quality and CPIA. Those will be the 2 categories, and those 25 points that they would have gained from the ACI category will be thrown into quality. So to 3x5 this, which is way too late for that because this plane has been flying for quite a long time, but let me just try to summarize. Physicians, you'll participate in all three performance categories. Physicians, assistants, nurse practitioners, etc. You'll participate in the quality performance category and the CPIA category. All right. Pick your pace. This was a really exciting announcement that Andy Slavitt made late last year to help folks in this transitional year. Everywhere you look, they've labeled 2017 the transitional year. They really are trying to help us be successful because they know this is all very new. So you've got 4 buckets of participation available to you. If you do absolutely nothing, you will get a 4% negative payment adjustment on your 2019 claims. If you do not participate in 2017, you will get the 4% payment adjustment. You all can root that all your neighbors choose that because then there's more money to distribute to those of you who do participate. Submit something. So this is the testing. They say, well, if you really don't think you're ready to participate, but you don't want to be assessed the penalty, you just want to remain neutral, you don't need the incentive, you don't want to get the penalty, you just are in this test phase, which is you can submit just the base score for ACI, you can submit a single clinical practice improvement activity, you can submit a single quality measure. No GlowStream users ought to opt for this. All of you ought to do either the partial or the full year because we're here to make this doable for you. The partial year is 90 days. It has to be at least 90 days, and then full year is clearly 365. It's important to note that this is not an either or. It's not either 90 days or 365. It's any range therein, 90 days to 365 days. I like folks to just get up and running as soon as possible and just make it part of your world because in 2018, they are holding out the possibility they'll give us another 90-day optional reporting period in 2018, but that's not in the rule yet. So this is kind of like, let's just get our good habits developed. Let's just make this part of our daily process so that when it is a full year reporting period, we just have good habits under our belts. So use this the way it's intended to be used, which is help you get up to speed gradually. I do want to address this little sentence at the bottom of this slide, which is the best way to earn the largest payment adjustment is to submit data on all performance categories. Positive adjustments are based on the performance data submitted, not the amount of information or length of time submitted. So that's this whole 90 versus 365. Is there an advantage to the full year reporting? And what they're telling us here is no, there really is not. I'm going to address this again in the FAQ section at the end, but I think, I read that, and for the longest time, we've been reading about MIPS and studying MIPS for the last over a year, ever since the proposed rule came out, and then when the final rule came out. And we've been, puzzling over well, why would I ever do the full year if I didn't have to? Is there an advantage? And really what it comes down to is the quality measures. You are required to meet a minimum case volume of 20 patients, and perhaps some of your quality measures in a 90-day period, you're not going to see 20 patients that fit that category. So that would be the reason to consider extending your actual reporting period. And we'll dive into that in a little more detail. Okay, so this is all about pick your pace. Oh, this is my favorite slide. If you get nothing else out of this webinar, I want you to focus on this. The reputational impact of your MIPS composite score. So for the folks who say, I just want to avoid the penalty. I don't want to work hard enough to earn any incentive money. I just want to avoid the penalty. So you're going to have a low MIPS composite score. You won't be penalized, but your score will be low, and guess what? Your patients are able to access this physician compare website, and they'll be able to see that you've got low quality scores. So this really is not just about your money. It's also about your reputation. And this is right out of the final rule. I've snipped this public reporting statement. So be aware, it's not just about your money. Okay, so we're going to dive into each of the performance categories: quality, improvement, advancing care, information. Obviously, cost is the one we're just going to table that for right now. And I think everybody at this point knows that the quality performance category is really based on PQRS. It replaces PQRS. The measures haven't changed. They are the same. Some have changed, but it's largely the same bucket of quality measures that we've been looking at for, at least on our CQM dashboard, for years. And the improvement activities, that's the brand new category. This is the one that's kind of new for folks. We'll talk a little bit about that. And then advancing care information is the one that replaces the meaningful use program. Cost replaces the value-based modifier. That was a program that was closely tied to PQRS, wherein PQRS is all about the quality of care. The cost, or the value-based modifier, was all about the cost of care. So these are the categories that will be used to determine your composite score, your MIPS composite score. And we'll have a scoring example later in the presentation. So quality performance category, formerly PQRS. I'm going to say that a million times because I want to make sure you all become very familiar with this. What's nice about it, though, even though it's based on PQRS, the reporting requirements are actually less than what we had to do for PQRS. Most of us will report up to 6 quality measures, including 1 outcome measure for a minimum of 90 days. That's what most of us are going to do. And guess what? There are bonus points available to us if I do an additional high priority measure. Our dashboard shows you which measures are high priority, so it's easy for you to make a good decision about that. You have to include 1, and if you include 2 or more, you get extra points. And our favorite feature is the ability to earn a bonus point for every one of those 6 quality measures if you report it using end-to-end electronic reporting. What is that? That is the QRDA3 file that you export from GlowStream. The Quality Measures Dashboard has a little button at the top that says QRDA3. You run your report, you click that button, and you'll upload it to CMS, and you will get 6 bonus points for reporting electronically. As with PQRS, you do still have the option for claims-based reporting, registry-based reporting to satisfy the quality performance category, but you would not earn those extra bonus points. This category is worth 60 points. It's 60% of your MIPS composite score. At the very bottom of this, kind of living outside of my little box, I'm talking about MIPS APM clinicians. This is just a blurb that you'll see throughout the 3 performance categories that we discussed to help anybody who's out there who's in an ACO. If you're in a Track 1 MSSP, part of your MIPS reporting will happen through your ACO, and so it's very important for you to be in touch with your ACO to understand that whole story. And in that scenario, your quality score is really reweighted to only 50%. It's 50 points. So just wanting to keep people aware that that is one of the options that's out there, and we'll talk about that a little bit later in the presentation. So the next category is the advancing care information. This is the one that was based on meaningful use. Back in the day, right, we were also dialed into the thresholds, right? Oh my gosh, I had to do greater than 10% of my patients had to have a patient-specific education, and greater than 80% of them had to have, I had to e-prescribe. That whole concept has been tossed out the door, and it's been replaced with a new concept regarding the base score and the performance score. So on your ACI dashboard, and GlowStream reflects this, and we'll show you an example, I need to meet 4 measures to get my 50%, my 50 points in the base score. Those 4 measures are listed here. Security risk analysis, you all know about that. It's where the folks come in and you walk around and you write up your policies and procedures regarding the security of your patient's health information. Once you've performed your security risk analysis, you'll make your dashboard say yes for that measure. So that's one of the 4 base score measures. E-prescribing, provide patient access and health information exchange. You must do each of those measures for a single patient, and we have to say this over and over again because it seems too good to be true, but you do this for one patient and you meet the base score. So e-prescribe one prescription, provide one patient access to the portal, and send one secure transition of, or I should say, summary of care upon transition of care. So health information exchange is sort of a new label for that old meaningful use measure that was all about the summary of care upon transition of care. So you refer your patient to another provider and you send a summary of care via direct messaging. Even if that's not part of your daily routine, do it for one patient in order to meet the base score. Then there is the concept of the performance score. So the remaining measures are and provide patient access and health information exchange actually are also part of the performance score. ERX is not. What this does is it gives us lots of opportunities to be flexible about the way we achieve our success in the ACI category. You may never send a secure message to a patient. You don't have to. You can focus your efforts on the other measures that do fit your scope of practice better. So we'll talk, this will make a little bit more sense when I'm showing the actual dashboard. And you can get bonus credit for public health reporting or using your certified EHR to complete the improvement activities category. And we'll give you a list of those improvement activities. We'll talk about a few of them that meet this 10-point bonus for the ACI category. Again, I have a little blurb here about the MIPS APM clinicians. If you are an ACO participant, your score in the ACI category, you will use GlowStream to generate your ACI score like you did your meaningful use score. We think the way this will happen is you'll submit that to your ACO. Your ACO will aggregate that across all participants in your ACO, and you will report one single ACI score for your entire ACO. So if you're in an ACO, you want to make sure that the community is being well educated about how they are to be successful in the ACI category, because your score will be lumped in with theirs. Then that category is reweighted to 30% in the if you're an ACO participant, which makes you a MIPS APM clinician. Okay, but for the rest of us, this is a 25. This counts 25% towards my MIPS composite score. And then this last brand new activity, or a performance category titled improvement activities, or sometimes you'll see CPIA, clinical practice improvement activities. The requirement here is that you're supposed to do up to 4. There's certain weightings. There's medium weight and high weight, and there's a combination that gets you to the right number of points. However, if you're in a group practice or you're a rural health professional, if you're a group practice, of less than 15. So I think most of our groups are less than 15. You actually can do just 2 medium activities for 90 days or a single high activity. If you're a PCMH, if you are certified as a PCMH, guess what? You automatically earn the full credit for this category, and that's a 15%. If you are in an ACO, if you're a MIPS APM clinician, you get full credit for this category. You don't have to do anything different or separate, and it's reweighted to 20% if you're a MIPS APM clinician. And then here we talk about cost just briefly, remembering that we don't have to worry about it this year, but next year it will be worth 10%. This really does replace the value-based modifier. It's going to compare resources used to treat similar care episodes and clinical condition groups. It can be risk adjusted to reflect external factors, right? So if you're treating someone who's sicker than than the guy down the street. They do risk adjust for that. There are 41 episodes that have been identified. These are the episodes that will be used to judge the cost of care. It is claims-based. There's no extra reporting that's required here. It's all based on your claims. But I think it's really important as a community. You want to be sure you understand the resource attribution models. So how is a patient being attributed to me? Right? There's some really sick patient that a lot of people take care of. How is that patient attributed to me? And you also want to be understanding the trigger events. There's certain events that trigger CMS to begin watching the cost of a particular patient that they're going to measure you against. So more on this to come. I just want to make sure everyone's aware this is on the horizon. Nothing we have to be worrying about just yet, though. Okay, reporting options. I've touched on this kind of throughout. As I mentioned earlier, if you are part of a Track 1 MSSP ACO, you will submit your ACI scores to the ACO. They will aggregate those scores across the group to achieve a single group ACI category score. That'll be added to the group quality performance score and then the automatic group CPIA category score. So there will be a single score for every person in that ACO. You'll all get one score. If you're not in an ACO, you've got two choices. If you're in a group, you can actually do group reporting this year for MIPS. So, and for the office managers out there who have attested for, 5, 6, 10, 12 different providers every year for meaningful use, you know how time-consuming that can be. They give you the option to do this at the group level, and that may be very appealing for folks. So you have to be within the same TIN, but you can do this. And if you've got mid-levels and hospital-based clinicians, I think this makes a really good solution. You'll run your quality dashboard at the group level. You'll take the ACI dashboards for the providers, and you'll just report as a group. If you are an individual reporting clinician, obviously the mid-level providers, we talked about this earlier, you'll reweight to the ACI performance, your ACI performance category points will be reweighted to quality, and then you'll submit that QRDA3 file to earn your 6 bonus points, and the CPIA will be reported via attestation for the 2017 reporting year. And then physicians, you will report all 3 performance categories, ACI, CPIA, and quality. You must submit any MIPS data to Medicare beginning Jan 1 of 18 and no later than March 31st of 18 to qualify for the positive or neutral payment adjustment, which will be reflected in your 2019 Medicare Part B payments. And you will avoid that negative 4% adjustment. All right, so that's a lot about the program. What's specifically going on here at Triarq? What are we doing to make this easier for you? So the new MIPS dashboards live in version 8081. This is a screenshot of what you see there. There's a quality dashboard, which is really, it'll be very familiar to you. It'll look very much like the old CQM dashboard, just with some new bells and whistles. There's a dashboard called ACI dashboard. That is shades of things to come. Don't use that one this year. You're going to use the 2017 ACI dashboard. This is all tied to our certification. We are 2014 edition certified as are most EMRs. We're in the same bucket with most EMRs out there. We're working our 2015 edition certification this year. Once we're 2015 edition certified, you'll use the ACI dashboard. So we'll be out of the transition year and we'll be using the main ACI dashboard, and there are more requirements on that dashboard. And we'll talk about that when the time is right. Okay, so here's the ACI dashboard. It's going to look kind of familiar, right? It looks a lot like that meaningful use dashboard that we were all used to looking at all these past few years. We've tried to help folks grasp the base versus performance score concept. So I'm looking at the screenshot right now, and I see in the column that's labeled base, I see 4 green checks. And I'm working with development because I think those green checks are misleading. They're meant to indicate that those measures are all part of the base, but I think the green check makes you feel like you took care of that already. And really, you need to focus on the numerator column to know whether or not you've taken care of business there. So notice that in the numerator for the security risk analysis, there's a drop down. It doesn't say yes. It doesn't. I need to make that say yes in order to satisfy that measure, right? I've got to go do my security risk analysis, and then I'll go manipulate my numerator on my dashboard to say yes. Likewise, the health information exchange, we see that it's part of the base, but right now there's a 0 in my numerator. That means I didn't do anything there. So be focused on your numerators here. Once that I've said yes to the numerator and sent one health information exchange, that base score up in the top little box that says base score, performance score, total, that will turn to 50. As soon as I meet those 4 base score measures, that base score is going to turn to 50. Then I can start looking at my performance score. We're calculating your performance score for you already, just so you can see, what your potential is. But those do not count. If you don't do the base, you do not count your performance score. If you get a 0 in the base score, you get a 0 for the entire category. So pay very close attention to this. So the summary, I did this as sort of a test case for Dr. Marcus Welby, and we can see that the feedback we're giving him is basically what I just said to you. If he does one summary of care and he completes the SRA, he's going to get the 50 points. He's going to add his 33 points out of a possible 90 from the performance category, and his total score will be 83 out of 100. And when you multiply that by the 25% that the ACI category is worth, he would contribute 20.75 out of a possible 25 points for the ACI category towards his MIPS composite score. So I want to talk just a little bit more about this concept of the performance score. So we are showing you in the last 2 columns, we've got one labeled performance and one is labeled max. Max is showing you what are the total maximum points I can get for that particular measure. Most are 10, 2 are 20, and this is representative of the fewer measures that are available to us in the transition dashboard as opposed to the ACI dashboard. So they doubled up on 2 of the measures, providing patient access and health information exchange. You can earn more points in those categories. It's really just math. We take the percentage, so 98.06%, you see that as the provide patient access. That's almost 100. We're saying, hey, that's essentially 100. That earns you 20 out of 20 points. So likewise, when I look at my view, download, transmit, 8.53, that's almost 10%. So you get 1 out of a possible 10 points. So your strategy ought to be view these different measures, decide what's a good fit for your practice, and then focus your efforts on getting your score as high as you can for those particular measures. These are all the same measures we've been looking at for meaningful use, just far fewer of them. There's less to have to fret over here. I really like to focus on the measures that are within my control, right? Patient-specific education. That's pretty easy to do. You can push it up to the portal. You can print it. As long as you are using your MU Patient Ed, that's one that's within your control, and you can get that score up higher. Same with medication reconciliation, or the medication reconciliation measure. Secure messaging. They switched the rule on this one. Now they're allowing us to increment the numerator when you reach out to your patient. So you don't have to wait for the patient to send you a message. You get to actually send them a message. So that's within your control as well. View, download, transmit, not so much, right? We're waiting for the patient to log into their portal account and view their health information. We can certainly do education to help folks understand what's required there. And I know folks who've been really successful putting a big effort into educating patients about their portal account during their visit, right? And showing them, hey, let's log into your portal account. Let's go click that button so you know what it looks like to see your health information, and all of a sudden the numerators are going up, which is pretty cool. So there's a lot of strategies that we can share with you on how to go about being successful, getting some of that incremented. So this is the ACI dashboard. Next is quality. So this should look familiar to folks who've been doing their CQMs for meaningful use for all these years. It looks a little different. There's a new column labeled quality categories. So you see where we're calling out the high priority, the outcome. There's a concept of cross-cutting, which was applicable in the PQS world. This was something that was part of the proposed rule that they sort of unwound it when they came out with the final rule, but I think that's temporary. So we left the cross-cutting indicator in our dashboard because I think that's coming back, but for now you can kind of ignore it. We've got some alerts and some warnings. So if you ran this dashboard for fewer than 6 measures, the system would honk at you and say, hey, the quality performance category requires at least 6. You're short, so add another one. So we're trying to help you be successful. What you're focused in on here is obviously the numerator over denominator, which is going to give you a percent. So that final column shows your percent score. That's going to be very important. Interestingly enough, that isn't your final score for the measure. And we'll talk a little bit about the deciles. This is where it gets super confusing. So every year CMS will publish a new set of benchmarks deciles. What you'll do is you'll run your dashboard, you'll look at your score. So if we look at this very first measure for preventive care and screening for influenza, if I look all the way over to the second to last column, it says provider percentage. This provider had 58.81 performance percentage, numerator over denominator, and that's going to earn him 8 points for that measure. And the reason for that is I look at that 58.81 and I say, oh, okay, that score landed in the 8th decile. I'm going to get 8 points for that measure. So I recommend you pick more than 6 measures to track. I like to do 8 or 9 just in case something goes haywire throughout the year. I've got some I can fall back on. I'm going to pick my best 6. I'm going to total those up. I'm going to give myself 6 bonus points for my EHR submission. If I do any extra high priority measures in addition to the one that's required, I'm going to give myself a bonus point for that as well. So this particular provider scored 52 out of 60 possible points in the quality performance category. That's pretty good. Improving activities. So this is that new category we keep talking about. The QPP website does a beautiful job of describing each of the improvement activities that are available. I've added 3 here to my screenshot. My very favorite one is this provide 24/7 access to eligible clinicians or groups who have real-time access to patients' medical records. If you read through the nitty-gritty here, this is what y'all are doing by having a portal. So read through this, make sure it feels like it's a good fit for you, and then I highly recommend you consider selecting this one. It does a couple things for us. It's weighted high, which means you have to do just one if you're in a group with fewer than 15 members. And it also counts in the 10 bonus points for the ACI category. So I like this one a lot. There are many others from which to choose. So the best advice I've got is to go out to the QPP website and check out the improvement activities and see what's a good fit for you. And CMS continues to come out with new information regarding, how they want us to track this. It's going to be, we're going to report to them via attestation, but we all like to prepare in the event of an audit, what is it that they would like to see from us. So they're continuing to publish new information for us so that we understand what those requirements would be. In addition to the dashboards, what else is available within the GlowStream product? We've got 2 flavors of quick guides. And hopefully everybody by now knows where to find the quick guides in the online help. So it's in the help menu. Any one of those items, user guide, search, or contents will take you to the online help. And then you can either navigate through the contents to find the EMR quick guides, or In this example, in version 8080, I think we're showing that we updated the original CQM workflow quick guides, and then we have new MU2 CQM simplified quick guides, and we really ought to rename those now that we're talking about MIPS quality. So I'll talk to the developers about that. So what's the difference between these two? So the original workflow quick guide, we really wanted to share with folks all the codification that goes into successful measurement on your CQM dashboard. That was no simple task, because in order to be a certified product, we have to be able to, in our certification testing, they can throw a patient at us that's got any number of blank codes, SNOMED codes, CVX codes, whatever it is that should be triggering the numerators and denominators. We have to accommodate that, and we have to show that our dashboard performs accordingly. So we felt like we really needed you guys to know what are all those codes, what should be in your system, so that if you're going to configure to successfully report on colonoscopy, what is it that the system is looking for? So we produced all those. We produced documents that included all those codes. Yikes, that was a lot of data, hard to navigate, hard to understand. So we took another shot at it and said, let's come up with what we call a simplified quick guide. That's 1 or 2 pages. It shows some screenshots, and it gives a really good understanding of what workflow is required. So these are the 2 examples. This is the uber detailed, every single possible BOINC code that might be attached to a fecal occult blood test that you either do in the office or get back through a lab interface. And oh boy, look at the FOBT kit in your office and find the BOINC code and add it to your test master, and now every time you enter a result, that BOINC code is a part of that patient's record and your numerator goes up. Yowzer, that was a lot of detail. So this is kind of the new version of what that would look like. We'd like to still give you a description of the measure, what's in the numerator, what's in the denominator, and then, what's the workflow all about? And so here we're showing a screenshot of, hey, build yourself a history item for colonoscopy tied to a SNOMED code that indicates colonoscopy was done, and make sure you document an office visit with a CPT code for indicating an office visit, and that patient's going to count in the denominator and the numerator, and you're good to go. So that's the difference between those 2 tools. Okay, so back to our MIPS case study. The doctor that we just walked through, let's look at, how would he score? So we first talked about his quality score. We said he was going to get 52 out of 60. And for ACI, assuming he does all the things we're telling him to do, your security risk assessment and his HIE, if he did both of those, he was going to get the full bonus, full base score, and then we were going to add his performance points, and he's going to get 20.75. And then, assuming he participates with it in the in the improvement activity, he's going to get his full 15 points there, which would get him a total of 87.75 for his MIPS composite score. That's a fantastic score. They're telling us that anything over 70 is going to put you into the bonus round. There will be, you'll earn the incentive, positive incentive adjustment, in addition to these this performance bonus. Again, they're not defining the amount of money that anybody's going to earn here, because again, this is a budget neutral program. I don't think I've mentioned that yet today. By that, we mean the losers have to support the winners. So the fewer people that participate, the more money there is to distribute among the winners. So be in the winner category. Okay, so I pulled together some FAQs. You may, I'm sure you can understand where these questions are coming from, right? We're talking about MIPS all the time. So I'm going to try and cover these. Oh, I've got 20 minutes. Awesome. We should get through this very easily. Okay. Some of this is going to be a rehash of things we've already covered, but I've watched so many CMS webinars, and I'll tell you, they spend about the first 10 or 15 minutes reviewing the exact same content every single time, and I think there's a value in that, because this is complicated, and I think it's helpful to hear the same things repeatedly. Maybe they'll sink in. Okay, so the first question, do you have to use the same reporting period for your ACI performance category that you use for your quality performance category? And the answer is no, which seems kind of weird because, historically our CQM dashboard was just an extension of our meaningful use. So CQMs were reported as part of meaningful use, so it had to be the same period. But in MIPS, ACI and quality are really individual performance categories within the same program, and you don't have to report the same time frame for both. That being said, we do recommend a minimum of 90 days for both, and CPIA is also a minimum. So let's just keep it simple for everybody, and let's say we're going to do a minimum of 90 days. All right. How does the practice know the goal percentage of the quality performance category measures? So we touched on this briefly earlier, but the concept of threshold or goal percentage that was just ruled our world in meaningful use has really been replaced with these new concepts. So in the ACI performance category, the one based on meaningful use, obviously we've got our base score. We've really beat this into the ground today. The base score is those 4 measures, including the security risk analysis, and 1 patient for each of the e-prescribing, HIE, and provide patient access. That will get us our 50 bonus points. And then once the base score, the 50 base points. Once that base score has been earned, then you can earn your additional points via the performance category. And that's all tied directly to numerator and denominator. For the quality performance category, there's kind of some new, there's not thresholds or goal percentages, but there's some new concepts to be aware of. The minimum sample size, you have to have 20 patients in your denominator to report a measure. So be watching that denominator, and we touched on this earlier in the presentation with respect to why you might extend your reporting period past 90 days. You may need to do that for some of your measures in order to get 20 in that denominator. Data completeness criteria. I banged my head against the wall for about 3 months on this one when they first published the first rule, and I was back and forth with CMS. They finally picked up the phone and called me. So we got to the bottom of it. I think what was so hard for us to understand was we're documenting all our patients in our EMR, so we're automatically meeting the data completeness criteria. So as long as every patient that you see gets a record and glow stream, and you're documenting them and picking their CPTs for their office visits, you are automatically meeting the data completeness criteria. And then the whole decile conversation, which we touched on as well. This is really kind of a new and wild way to be measuring success, right? I can't just look at my performance, and there's some really interesting deciles out there. And I probably should have highlighted that. Hang on and close your eyes while I zoom back up to that screen. I want to show you guys something that I should have highlighted here. Yeah, this is it. So back to the decile conversation. This measure, documentation of current meds in the medical record, we're all really good at that. We've been doing that for years for meaningful use. It was a CQM, so it was kind of something. It continues to be, I can really kill 2 birds with this one stone. But look at what my performance percentage needs to be in order to get 9. 9 is the maximum. I can't even get 10 points because I have to be performing at 99.75% to get in the 9th decile. So this is practically, well, actually, I guess it is already topped out. See this column that says topped out? What this means is we got really good at this, so they don't care about collecting this data anymore, and that will probably be removed. So the deciles are really tricky, and when you're picking your measures in the quality performance category, I think it bears reviewing. I like to look through this decile number 10 and say, all right, let's see. Ooh, that's a pretty low bar. 46% for my preventive care and screening for high blood pressure with documented follow-up. If I do that for 46% of my patients, wow, I'm going to be getting a 10. So I think this bears understanding when you're selecting your measure. So that's the whole decile story. All right, I'm going back to my FAQs. Close your eyes. Okay. So our second page of FAQs. My numerators are not incrementing for my measures that are tied to lab results, yet I am receiving lab results via the interface. We see this. So guess what? Some labs do not send the LOINC code that is required for incrementing the numerator. They don't send it in their HL7 message that we receive across the interface. I know personally I've called a lab here locally and said, what's up guys? I think this is a standard. You should be sending us a LOINC code. We've got one local hospital that does send them and one that doesn't, and that stinks. The labs need to be sending LOINC codes in their HL7 messages so that you can so that our dashboard can detect the fact that you did the A1C, you did the microalbumin, you did the chlamydia test, you did, whatever it is that, you're trying to measure. If you've picked a measure, you want to make sure that your local lab is sending you HL7 messages. If you perform, say you do the hemoglobin A1C in-house, and if you go pull out your test kit, it will list a LOINC code. LOINC is very tied to, there can be, I want to say for glucose alone, there's like 35 different LOINC codes that's based on the reagent that's used, the instrumentation that's used. So this is not anything we invented. We just have to comply. So if you are doing a test in-house that you want to have count towards your quality measures dashboard, open up your test master for that test and go throw the LOINC code into the results section. Pull that off your test kit and put it in there. And then every time you enter a result, that LOINC code is tied to that patient record and your numerator will increment. Speaking of hemoglobin A1C, I am documenting that darn value on every diabetic and my numerator is like 0. Well, guess what? That's actually a good score. The hemoglobin A1C measure is an inverse measure. If you read it carefully, it's hemoglobin A1C in poor control. So if you don't measure it, or if it's over 9, your numerator is going up. That's bad. You want this to be a low. One. So be aware of what it is that constitutes success for each measure. Smoking status and tobacco cessation counseling. Man, we were doing great on that for years and years, and all of a sudden it's 0. What is going on? Well, guess what? CMS changed the rule. It's not enough to just document the patient's smoking status anymore. No. You have to order the smoking status assessment before you enter the smoking status. Well, I cry foul, and we're not making you do that. We're going to tie the required LOINC code to the smoking status for you. So bear with us. We are handling this in the background so that you don't have to jump through extra hoops for this. And your numerators will come back up as soon as we get you on the right version. So hang in there. And it will be retroactive. So don't throw out that measure if it's a good one for you. Okay. The measures on the GlowStream Quality Measures Dashboard are largely geared toward primary care. What about us specialists? Yes, I hear this all the time. I think there's 290 quality measures out there. We're certified for 24. We picked those 24 carefully. It's a tremendous amount of work to get them built because of all of the codification that goes in, and I could go on and on and on. But it's our hope that everybody will be able to find 6 measures. If you can't, let us try and help you, please. I do want folks to keep in mind that it's not that you don't necessarily have to administer, like for example, flu and pneumonia. You can gather data regarding someone's health maintenance items. You don't have to be the one that gives the flu shot or the pneumonia or orders the colonoscopy or orders the mammogram. But you can build those items in history, tie them to the proper SNOMED codes, and then click on those and to increment your numerator. So we're hoping that everybody can be successful. If you just can't stomach the 24 that are available on our dashboard, you do still have the option to do claims-based reporting and registry-based reporting. You just wouldn't get those 6 bonus points. Okay, is it important for me to report for more than 90 days this year? We've touched on this a couple times. we're saying, yes, we think you should report for at least 90 days, but you can report for any time frame between 90 and 365. There's no advantage to submitting more data or for reporting for a greater length of time. And as we've said a couple different times, the reason for reporting for more than 90 days would be to increase denominator for quality measures in order to achieve that minimum case volume of 20 patients. How do I get the most recent version of these MIPS dashboards? You want to be on 8081. If you're in our cloud, then it just couldn't be any easier. Send us a request to incident@triarqhealth.com and we will get you scheduled to update. If you're still using an on-prem server, then contact your IT partner, enabling us to gain access to your server, and once that's done, we can schedule your update. All right, so how can I get more help with all this MIPS stuff? So we are already working very closely with all our QPro and QComplete customers to help them with MIPS. As a QPro customer, we will establish a MIPS strategy and plan for you, including recommendation measures to you, training on the workflows to meet those measures, and we'll proactively monitor your progress and dashboards. At regular intervals we get between now and the end of the year, we will also deliver to you a written summary of where you are with MIPS and any gaps and recommendations for improvement. So here's a teeny weeny little example. I'm going to try and pull up, let's see if I can go find this. Where am I? There it is. All right. Let's see if we can, oh, no, that's a screenshot. I don't need the screenshot. Okay, there's my Word doc. All right, and I'm going to try and make this bigger and see, I want to do, does that work? Here we go. Okay, so this is an example of something that we've pulled together. So you guys are getting used to looking at this, this dashboard. I'm going to make this a little bit smaller so I can show. So what we like to do is meet with you and then follow up with some documentation that you can save and reference at a later time. So basically what's going on here is, you know, we're giving you an analysis of where are you with your ACI dashboard. So, right, great emphasis on this whole base score. You've got to do, you know, here's the things you're outstanding for, your security risk analysis and your health information exchange. Let's make sure that you execute on those two measures so you can get your full 50 base score. And now, how are you doing in your performance score? Guess what? You're doing really well, and we can add those performance points to the base score to get you a really great category score. Then we take a look at your quality measures dashboard, and we do this translation for you. So you don't have to master the whole decile story. If you work with us, we just take care of this for you. So we do the translating for you. We help you understand you know, what percentage lands you with which deciles, et cetera. And then we work with you if you say, you know, I really want to get my score higher for preventive care and screening for high blood pressure and follow-up. What do I need to do to get that 3 to be a higher score? And we work with you to make sure you understand the workflow so that you can improve your numerators. Same story with the CPIA. We review the list at QPP with you, help you understand what we think is, you got a little free advice today with our, we did the work for you, right? We found the CPIA that's the high weight that also counts the 10 bonus points for ACI category. And then we do a nice summary for you at the end and say, hey, if you continue on this path and you do these few things that you're required to do, this is what your potential composite score is going to be. And then we just continue to monitor those dashboards to make sure that, that you are continuing on the right path. So let's head back to the PowerPoint. I think I went too far. Oh, we get to see my kids for a second. All right, let's see. Where are we? There we go. All right. So how do we get you there? So we talked a little bit about QComplete and QPro. I feel like I should hand it over to the sales guys to talk about this one. I don't do it justice. I just deliver the service. They're really good at selling the service. So QPro and QComplete. With either program, you get a performance manager. You get our experts' advice. We manage the process for you. We work with you on reports. We meet with you. We kind of hound you I like to think of myself as a fairy godmother, making sure that you don't mess it up. We're going to work with you, make sure you don't miss it. We consult on workflows. We do continuing education. So lots of great features in the performance management program. We also work with you on policies, procedures, materials, and training. So what are the best practice workflows? How can you best engage your patients, right? MIPS and meaningful use, PQRS, but really essentially with MIPS, huge focus on patient engagement. That's why so much of what you're seeing is focused towards getting the patient engaged in their own healthcare, right? We all know how important that is. Their hemoglobin A1C result is going to continue to be bad if they don't get busy with their diet and exercise. There's only so much you can do to control that, right? We need the patients engaged in their healthcare. So we help you implement new workflows and monitor. Also, obviously, with QPro and QComplete, the platform and tools, our EMR, our PM, our cloud, the portal, interfaces, direct messaging, statements, e-prescribing of controlled substances. We've got 2 new fun, exciting features coming out with our RX Meds. Complete EPA, which is electronic prior authorization for medications, as well as PDR, which is some really cool coupons that can be printed for the patient to get a discount on their medication. So talk about engaging the patient in their health care. Let's make it a little less expensive for them to fill their meds. So shades of things to come in 80/90. Online bill pay, credit card on file, and available interfaces. So what's next for you? Make sure you get educated, and attending today's webinar is a great first step. CMS also has a lot of good content. You want to make sure you've developed a plan, work with your team. You've got to have a champion in your practice. You've got to have someone who is running point on this effort, whose job it is to make sure that the dashboards are looking good. And do not delay. This is not going away. Take advantage of the 2017 transition year to get yourself up to speed for 2018. And again, the delay was not a reprieve. This is not going away, so do not ignore this. So our big message is to get out in front and thrive in this new value-based care market. You want to market your quality and earn incentive, significant incentives, right? We talked about the reputational impact of your quality scores. Tracking and reporting your quality can help you negotiate with payers. That's a side benefit. Be ready with your quality scores and quality metrics and demonstrate high quality. If you resist, you are going to struggle. We're here to help you, and we can help you get there. So this last slide here is all the folks at Triarq that are standing at the ready to help you. Brent and Patrick are sitting here with me, and they're ready to catch whatever you want to throw at them. Brent, do you have any closing words?
So thanks for your time, Julie. It was informative, I'm sure, for everybody. If you'd like to hear a recording of the webinar, we're going to put it up here shortly on the Help Center, which you can find at help.glowstream.com. Other than that, you can expect to have your territory managers to reach out to you and follow up. So we thank everybody for their time today, and take care.